All right, let's get started. Okay, here are my disclosures. So at the end of this, I hope you will be able to describe the epidemiology of the hepatitis C virus and the natural history of this disease, to discuss the considerations in selecting treatment for individuals with hepatitis, and also be able to recognize therapeutic classes of medications with the potential for clinically significant drug interactions with hepatitis C meds. Virus. This is an electron micrograph of it. It's a single-stranded RNA virus. It's blood-borne. It replicates primarily in the liver. And there are at least 6 different types of hepatitis C that have been identified. These are the different genotypes. They range from 1 to 6. And then within those genotypes, there are different subtypes. Subtype 1A and subtype 1B. So genotype 1 is the most common in the United States. It represents about 75% of cases, followed by genotypes 2 and 3, which together make up the remainder. The replication of this virus is highly error-prone. So there are about 1 trillion copies produced each day. So even before someone is treated for hepatitis C, they already have some viral resistance mutations that may make the treatment, treatment choices a little more complicated. So about 3% of the world's population, that's about 185 million people, have hepatitis C. Official numbers in the United States suggest that about 3 million people have hepatitis C, but it's probably closer to 5 million. And that's because a lot of people don't get counted in these official statistics that represent a large proportion of the individuals with hep C, like inmates or veterans or homeless individuals. 3/4 of the people in the United States living with hepatitis C are baby boomers, born between 1945 and 1965. In countries that do liver transplants, hepatitis C is the leading indication for liver transplants. And this disease has a very slow, insidious onset. So even though rates of new infections have declined, we still have infections from decades prior that are now just beginning to place a substantial burden on our healthcare system. And because of the slow, insidious onset of this disease, many people don't know they have it. They're not showing symptoms, so they're unaware of their status. As I mentioned, rates of new infections in the U.S. have declined, but there's still some populations where we're seeing actually an increase in new cases of hepatitis C, primarily in suburban white kids that get hooked on OxyContin or other prescription pain pills and then switch to using heroin, IV heroin, because it's cheaper and easier to access. So that is where we are seeing an increase. And also the official numbers that get reported to CDC, studies show they don't come near to what the actual rates of new infections are. Okay, so this is a description of the natural history of this disease. Okay, so in an individual that's infected with hepatitis C, they may or may not show symptoms. If they do show symptoms, they may have some jaundice and may have some right quadrant pain, things that would suggest that maybe they were sick with a GI bug or something of that nature. But not everyone shows symptoms. About 85% of these individuals that get infected with hepatitis C will not clear it on their own, but will go on to have chronic hepatitis C. And with that comes possible complications of having a chronic liver disease. So about 20 to 30% of people with chronic hepatitis C will get cirrhosis. An additional 5 to 10% of those individuals will progress to having something called decompensated cirrhosis or hepatocellular carcinoma. And once you develop hepatocellular carcinoma or decompensated liver disease, the only cure is a liver transplant in many cases, and there aren't enough livers to go around. And they carry a high mortality rate. So decompensated liver disease, for instance, the survival rate after 5 years of diagnosis of this is only about 12%. So what does decompensated liver disease mean? Well, these are pictures of the complications of decompensated liver disease. It's a clinical diagnosis, not a laboratory diagnosis. So you may see yellowing of the skin or eyes. That's shown here because of the accumulation of bilirubin. Patients can develop hepatic encephalopathy. You can also get, this is not a pregnant person, this is ascites, fluid accumulation, because our liver makes plasma proteins, and that keeps the fluid in the places where it's supposed to stay, And then when you quit making those plasma proteins, you have accumulation of fluid. You may also have patients that develop esophageal varices. So as your liver gets stiff and it gets hard, the blood that would typically go back through the liver to get to the heart can't go that way anymore. It's like going home on I-70 and there's a big accident on a Sunday evening after skiing. You can't go down I-70. You have to find other ways to get around, to get home. So that's what the varices in the esophagus are. They're vessels that have swollen to try to pick up the slack from the vessels that would typically go back through the liver to return to the heart. These vessels are fragile, and so they can bulge, and you can see a little bit of blood in this picture here. They can burst, and they can cause patients to potentially die of a GI bleed. Okay, so that's what decompensated liver disease is. About 15% of people that get infected with hepatitis C will clear it on their own. And so there's research trying to determine exactly what makes a person clear hepatitis C versus what makes them go on to develop chronic disease. Okay, so according to Markov models, we have not hit our peak of complications from hep C infections from previous decades. So they estimate that without effective treatment, the majority of the complications from hep C are going to occur in about 2032 or 2033. So we need to do something. Otherwise, we're going to have a lot of individuals that are very sick in the coming years. So to answer one of the first audience response questions, hep C is curable. So why is it curable, but HIV and hepatitis B are not curable? Well, HIV integrates into our host genetic material in order to make copies of itself. So it's always sitting there in those cells, and the cells that are kind of quiet or asleep, once they wake up, they start replicating the virus again. For hepatitis B, it leaves behind pieces of its genetic material in the nucleus of the host cell. So it too, once cells sort of wake up, can make copies of itself. Hepatitis C, however, replicates entirely within the cytoplasm, doesn't get into the nucleus of the cell, therefore is curable. We use a chicken word for cure, sustained virologic response, but it is tantamount to a cure. So we measure SVR 12 weeks after completing treatment. If an individual at that time has a hepatitis C RNA or a hepatitis C viral load that is undetectable, then we consider them to have achieved SVR or to have had a cure of this disease. And once you achieve SVR, the complications of chronic liver disease, and not just liver-related mortality, but all-cause mortality, are substantially reduced. But there are some hurdles to getting to the treatment. I found this on ClipArt, and it had the smaller hurdles, and then they built up, but really it should be flipped. The biggest hurdle is diagnosis. So we need to get people tested to know that they have hepatitis C. The next hurdle is linkage to care. So some people know they have hepatitis C, but haven't gotten into care with a hepatologist, a GI doc, or an ID doc, or other type of provider that could treat them. And you can kind of understand that because for years we had been using interferon-based therapy, which was horribly tolerated and achieved only about a 50% cure rate on average. So people were kind of thinking, why even bother going to see about the liver disease because the treatment's worse than the disease. Now the hurdle, once you get past those two things, okay, I'm diagnosed, I've been linked to care, is cost and access of the treatments. So they are expensive. And there are a lot of restrictions on obtaining the medications. And I'll talk about some of the restrictions through Colorado Medicaid as an example. So the result is that of all Americans living with hepatitis C, only 5 to 6% of them have ever been successfully treated and cured. So that's a really small percentage. We'd like to increase that. So who should we test for hepatitis C? We should test all baby boomers, regardless of risk factors. So if you're born between 1945 and 1965, you get a one-time hepatitis C antibody test. Okay? Other groups we test based on their risk factors. And these are the risk factors. So ever injected drugs. And this could also be extended to sharing drug paraphernalia. So for instance, if you had used cocaine and shared straws, might want to be tested or test those individuals as well. If you've ever received clotting factors made before 1987 or a blood transfusion before July of 1992, before we started testing for hepatitis C. If you've received hemodialysis ever, because for some reason there has been a high rate of hepatitis C antibody positivity in individuals who have ever received hemodialysis. We think this could have been a problem with dirty equipment. We certainly hope it's not a problem anymore, but that is a risk factor and a reason that people should be tested. And in case you think that all this dirty equipment stuff should be happening in other countries and not happening in our own, it does happen here. Several years ago in Las Vegas, we had GI docs reusing colonoscopy equipment, which transmitted hepatitis C. We had a dentist here a few years ago, and maybe some of you remember there was a scrub tech at Rose who had been injecting herself with fentanyl and then filling the syringes back up with saline before patients had surgeries. And so there were cases of acute hep C from that as well. A good thing to come from some of that, if there is a good thing, is that a lot of people were tested for hepatitis C when these things occurred. So all the patients of that dentist, all the patients that had had surgery at Rose over that 6-month to 1-year period, they actually can tell whether or not the virus came from the dentist or from the scrub tech. And some cases certainly did, but many did not. So many of these people were able to determine that they had hepatitis C and do something about it when maybe they wouldn't have normally been tested. Anyway, I digress. Okay, another risk factor would be HIV co-infection because of similar routes of transmission. Unexplained elevated LFTs. So if your liver function tests are elevated, we don't know why, you could have hepatitis C. And then we test all people who've been in settings where there's a high prevalence of hep C, such as in prisons. We should also test people based on the need for exposure management if they've had an exposure. So that could mean healthcare workers that came into contact with a dirty needle, children born to hepatitis C positive mothers. So the rate of vertical transmission, that's another term for this, is small. It's about 5%. But we still want to test those children and know if they have hepatitis C so that we can plan for their care moving forward. Also, sexual partners of hepatitis C infected persons. So I always blush when I say this, but sexual transmission of hepatitis C is inefficient for heterosexual vanilla once a week. But there are types of intercourse where there's a lot of blood exchanged, where you can see high rates of transmission of hepatitis C. Okay, I got through it. Okay. Okay, so how do we diagnose hepatitis C? Well, the first thing you do is a hepatitis antibody. Okay, if the antibody test is negative, then you don't have hep C, unless you think the exposure has been within the last 6 months. And at that time, if it's been within the last 6 months, the antibody may or may not have turned positive yet. So we would also get a hepatitis C viral load in the blood to see if it's replicating. Okay, so you can't always assume that just because the antibody test is negative that the person doesn't have hep C. But if they haven't had any risk factors in the past 6 months, then that's probably a good indication that they don't. If they do have a positive antibody, the next thing we do is get a hepatitis C viral load test. And that's because we need to be able to distinguish active infection from prior infection and then spontaneous clearance of the virus. So they could have cleared it on their own. Remember, it's about 15% of people who can clear it on their own. So the way we would distinguish is with a viral load. Okay? There's not commercially available ways to distinguish a false positive antibody from actually having contracted the disease and clearing it. So you would have to, if you wanted to know this for some reason, you would have to ask for some additional testing. Okay, now once we've been diagnosed, the next step is to get into care and to stage liver disease. So we want to know what shape your liver's in, and because this will determine the urgency for treatment. Do you need it right away? And whether or not you need additional monitoring. So if you have really advanced liver disease or cirrhosis and beyond, then you may need additional screening for esophageal varices or hepatocellular carcinoma. So we have a couple different options for staging the severity of the liver. The oldest one is a liver biopsy, but this is invasive. It involves putting a big needle in and pulling out a piece of liver tissue and then doing the histology on it. So in the past few years, we've moved away from biopsy a bit and towards using a combination of serum biomarker measures like platelet counts and AST, and you can do a calculation from that, and coupling that with an ultrasound-like measure, so transient elastography or magnetic resonance elastography. Either of those two tests coupled with a blood test give us a pretty good indication of whether or not someone has no fibrosis or whether someone has cirrhosis. It's not so good in between, but sometimes that there's not as much urgency to distinguish those two. It's more important just to know if someone has cirrhosis or not. So if you do a liver biopsy, this is what the results look like. It's on a score of 0 to 4. 0 having the least fibrosis, 4 having advanced fibrosis. They call that cirrhosis. So a score of 4 is considered cirrhosis. So blue is bad. So the more blue you have, the more advanced the liver disease. And you can understand that because we're using a small needle, that these patients that have stage 3, they might actually have cirrhosis. We just happen to sample from an area that didn't look so bad. So sometimes we still treat people that have stage 3 as if they have cirrhosis, just because we can't be sure that they don't. So one of the big reasons that people didn't want to get into care is because the treatment was so horrible, as I mentioned. And that's because we were using interferon. We gave it once a week. It was an injection, and it was pretty miserable. We have fortunately left this drug behind. Rest in peace, good riddance, right? So this is the evolution of hepatitis C treatment. So on the y-axis, you'll see the cure rates, SVR rates. On the x-axis, you'll see time. And then the blue bars represent different types of treatment, how we were treating the disease at the time. Okay, so first we had interferon alone. This mouth is getting to me. Okay, so we used that for 6 months. It was an injection given 3 times a week, and we cured 6% of people. Whoop-de-doo, right? So we then extended the duration to 12 months. We could cure on average about 16% of people. Serendipitously, we figured out that the broad-spectrum antiviral drug ribavirin, which is an oral guanosine, adenosine type analog, improved cure rates. We still, to this day, don't know exactly how or exactly why, but it does. So the addition of that to interferon brought the average cure rate up to about 42%. Then we pegylated the interferon, gave it a bulky moiety that we attached to it that gave it a longer half-life, and that allowed for less frequent dosing. We were able to give it once a week instead of 3 times a week. And so those sustained levels probably increased cure rates, as well as it probably improved adherence, because now you don't have to do your shot 3 days a week, just 1. The big breakthrough, though, came in 2011. This is when we had our very first drugs that were direct-acting against the hepatitis C virals. So we call them DAAs, direct-acting antiviral agents. These drugs were called telaprevir and boceprevir. Who saw those drugs? Who dispensed those? See a couple of you. They were a benefit in that they improved cure rates. On average, about 30%. God, were they horrible. I mean, they required a large pill burden, 3 times a day dosing because they had such unfavorable pharmacokinetics, and 99% of people had side effects from the treatment. It had to be combined with interferon and ribavirin, so you still had the contraindications to that therapy as well as the side effects from that therapy. So it was really difficult to tolerate. In 2013, the NS5B polymerase inhibitor sofosbuvir was approved. And when this drug came out, we were all thrilled because it has a really wide therapeutic index, very well tolerated, one pill once a day, few drug interactions. When it first became available, it was licensed for use in combination still with interferon and ribavirin, but the treatment duration was much shorter, only 12 weeks, and you had a better than 90% chance of cure. So it was a big deal, but really we wanted to use it without interferon and ribavirin. Cimeprevir was another hepatitis C protease inhibitor approved at about the same time. Much better than telaprevir and boceprevir because it was one pill once a day and much better tolerated. So many providers started using those two drugs in combination, even though they didn't have regulatory approval, either agent for that combination. They still use them together with good success. But in 2014, sofosbuvir was approved in a fixed-dose combination tablet with another medication called lodipisphere. That's an NS5A inhibitor. And so that drug has really kind of become the gold standard. AbbVie also had some drugs come out, which I'll talk about later. At the same time, these are also used. So really, we've made significant strides in the past 3 years. Why did it take 20 years to get there? Well, we didn't have a decent animal model for hepatitis C. The only animal that can be naturally infected with hepatitis C is the chimpanzee, and chimpanzees are endangered. So there's also a lot of expense with studying them. Now we have a humanized mouse model we can use. There was also an inability to achieve hep C replication in cell culture. So it makes it kind of hard to come up with a new drug when you can't figure out exactly what the drug targets are or study them. Once those two obstacles were overcome, though, the floodgates opened. At one time, there were more than 36 drugs in development for the treatment of hepatitis C, which is really unprecedented in the history of drug development for any disease. So it was a really exciting time for me. So this is the hepatitis C genome, about 9,600 base pairs in length. It encodes for 10 proteins, some of them structural, others related to viral replication. And all of the approved medications and the ones that will be approved in the very near future target 3 proteins. The NS3 protease enzyme, which the job of the protease is like scissors, it cleaves the downstream replication complex. If you can't cleave that, then it's non-functional. The NS5A protein, which we don't exactly know how this works. We know it has an important job in replication and maturation, but we're not completely sure of how it works. And then the NS5B polymerase. So for those of you familiar with HIV and you've seen AZT and tenofovir and stavudine, sofosbuvir is in that same category. It's a nucleoside or nucleotide analog, so it competes directly with endogenous bases for incorporation into replicating virus. The non-nucleoside inhibitor disabovir binds NS5B, but it does so in an allosteric site, so it's not a competitive inhibitor. So the drugs I'm going to talk about today are cimeprevir, paritaprevir, and grazoprevir. These are protease inhibitors. Lodipisphere, ombidisphere, decladisphere, and elbasvir. These are NS5A inhibitors. And then sofosbuvir and disabovir, which are NS5B polymerase inhibitors. How do I keep all these names straight? Well, one thing helps me. All the protease inhibitors end in evir. The NS5A inhibitors end in asvir. And the NS5B polymerase inhibitors end in buvir. So that helps me keep up with them a little bit. So before I start talking about specific drugs, I want to give you some generalities about the treatment of hepatitis C. So the first is, it's just like HIV in that we're going to use a combination of drugs. Because when we use a combination, we can maximally suppress the virus and prevent the emergence of resistance. When we gave some of these drugs as monotherapy, resistance emerges pretty rapidly. The treatment duration now is typically 12 weeks, but can range from 8 to 24 weeks. Several agents are co-formulated, so that improves adherence. Ribavirin is still used, which is good news for me because I've done a lot of work with ribavirin, but the field would like to move away from use of this drug because it too has some toxicities, predominantly like hemolytic anemia. Compared to peg interferon and ribavirin treatment, all of our therapies now are pretty well tolerated, actually really well tolerated compared to that. But cost and access really impacts treatment choice. If your insurance provider only allows for one treatment, well, that's the treatment you're most likely going to get. Okay, so the first treatment is sofosbuvir and ledipasvir. Have you seen commercials for this? Yeah, some of you have. I think they ran a commercial during the Super Bowl. But it's one pill once a day. It's approved for genotypes 1, 4, 5, and 6. It has a low potential for drug interactions, but it has one very important drug interaction. Ledipasvir absorption is pH dependent. It needs an acidic environment for optimal absorption. So if you give it with gastric acid modifiers, which are going to increase the gastric pH, you could decrease the absorption. This is the treatment of choice for individuals with decompensated liver disease, but you have to use it with ribavirin. So when these two drugs were given by themselves, they only had about a 63% cure rate. When you give it with ribavirin, now you're talking 80 to 90%. And so this is good news. These are really sick patients, and we are able to improve their liver function enough sometimes that they come off the liver transplant list. The most important thing to remember about sofosbuvir is that it cannot be used in individuals with a creatinine clearance of less than 30. The company hasn't figured out yet exactly how to dose the drug in this situation. There have been several case reports or case series of investigators who have used it in this population, and it looks okay, but it's still a small number of patients. So I think we still need more data to feel comfortable with that. So bottom line, the niche for this, it's a preferred treatment for most situations, but not all. Okay, another option that is an NS5B polymerase inhibitor and an NS5A is sofosbuvir and decladisvir. Because it comes from two different drug companies, you've got two different pills. You also have a higher cost than the therapy that I just discussed because it's two different companies. So this is seldom used compared to sofosbuvir and ledipasvir, but its one niche may be genotype 3. So individuals with genotype 3 don't respond as well to sofosbuvir ledipasvir as they do to sofosbuvir decladisvir. Decladisvir has better activity against genotype 3. So that's the niche here for this treatment. So who's familiar with dispensing Maraviroc? Okay, not many of you. Well, the dosing for this medication is like Maraviroc in that typically you'd get 60 milligrams, but if you are on a moderate inducer, you need to increase the dose of decladisvir from 60 milligrams to 90 milligrams. And if you're using an inhibitor, you need to decrease the dose from 60 milligrams to 30 milligrams. So the niche is genotype 3. Okay, I didn't put an image in of grazoprevir and elbasvir because this was just recently approved, so within the last few weeks. This is also a one pill once daily therapy, but it doesn't contain sofosbuvir. It contains an hep C protease inhibitor, grazoprevir, and an NS5A inhibitor, elbasvir. This is approved for genotypes 1 and 4. In individuals that have genotype 1A subtype, so an easy way to think of those is 1B, B is better, 1A, A is awful. It's not really awful, but it just helps me remember that. If you have genotype 1A, you need to have a resistance test, a viral resistance test before you use this treatment to see if you have any NS5A resistance mutations. If you do have some of these viral variants at baseline, then you're going to need the addition of ribavirin and you're going to need an additional 4 weeks of treatment. So typically a patient would get 12 weeks. These individuals will need 16 weeks. And the niche for this therapy really is in renal impairment. So neither elbasvir or grazoprevir have altered PK in individuals with impaired renal function. And in fact, they've studied this in about 224 individuals with very advanced kidney disease, and it had a 94% SVR rate by intention to treat. So it looked really good. It was very well tolerated. So that is the niche for this treatment. However, protease inhibitors tend to have a lot of drug interactions, and grazoprevir is not an exception. So remember to screen for drug interactions with this regimen. So the niche is renal impairment. Oh, and cost. So the cost of this therapy is a lot cheaper than the AbbVie therapy and the sofosbuvir-ledipasvir. So I imagine in the coming months there's going to be price battles between the three drug companies with certain insurance companies and Medicaid programs to see which ones can win out. So this is a treatment that includes several drugs. Ritonavir boosted paritaprevir. Paritaprevir is a protease inhibitor. Ombidisvir, which is an NS5A inhibitor, and dasabavir, which is a non-nucleoside NS5B polymerase inhibitor. And it comes in this pack. The pink pills are the ritonavir boosted paritaprevir and ombidisvir. Those are co-formulated. And then the orange ones, that's the dasabavir. It has to be given twice a day. That's the non-nuc. So the purpose of ritonavir is actually not to inhibit hep C replication at all. It is used because it blocks CYP3A4, and so you have an enhanced exposure of the paritaprevir, and you're able to give it once a day. So that's the purpose of this, to act as a booster or a pharmacokinetic enhancer. Individuals that have genotype 4 disease can use just the pro part of this, the ritonavir, paritaprevir, and ombidisvir. They don't need the dasabavir. But individuals with genotype 1A also need ribavirin. And so it's similar to the grazoprevir-elbasvir in that these patients may have baseline NS5A variants, and the ribavirin just helps them get a higher cure rate. Okay, and you have a higher pill burden than the treatments I showed you previously with this therapy, and especially if you're now adding ribavirin. So the pills at the bottom here, all the ribavirins you might have to take if you have genotype 1A. So all protease inhibitors have increased exposures in hepatic impairment. So therefore, individuals with Child-Pugh B or C, otherwise known as decompensated liver disease, cannot receive protease inhibitor-based hep C therapy at this time. So if you use this even in cirrhotics, you may want to do some additional liver function tests. And this therapy has a lot of drug interactions. So the niche, really, it's cheaper than sofosbuvir-ledipasvir, and that's right now its only niche, in my opinion. Okay, the last treatment I'll talk about is sofosbuvir-simeprevir. And I'm not going to talk about this much because it's just really not used anymore. I told you that it was the first interferon-free therapy, so people used it in that situation because that was all they had. But now that we have sofosbuvir-ledipasvir or the Merck regimen or the AbbVie regimen, then we don't use this treatment as much. Okay, so now I'm going to go through a patient case just to give you a sense for what we think about. This is a 60-year-old male with a history of IV drug use in the 1960s and 1970s, and he was diagnosed with hepatitis C genotype 1B about a year ago. He had persistently elevated LFTs, but remember, he didn't need a reason to be tested for hepatitis C. He was born between 1945 and 1965, so he should have been tested regardless of risk factors. But anyway, he had a risk factor. He had persistently elevated LFTs. He's never been treated for his hepatitis C. He had a liver biopsy, and it showed that he had stage 4 fibrosis. So how significant was his liver damage? Very. He had cirrhosis, but he has no history of ascites, edema, or hepatic encephalopathy. So he doesn't have, which type of cirrhosis does he not have? He doesn't have decompensated. He's cirrhotic, but he's compensated, so he's not decompensated. Okay, the only medication he takes right now is omeprazole, 20 milligrams once a day. And then in terms of his labs, he has a slightly elevated bilirubin. His platelets are a little bit low. That can be a sign when it gets below 100 of having some portal hypertension, which is yet another complication of having advanced liver disease. His viral load was about 1 million, and he has normal renal function. So we estimated his creatinine clearance to be about 102. Okay, so here are some considerations for treating this particular patient. What type of genotype does he have? Is he treatment experienced? How severe is the liver disease? What medications will he have access to based on his insurance coverage? Drug interactions, comorbidities. And really, the only issue with the comorbidities other than renal impairment is the potential for drug interactions because they might be on medications that interact with this therapy. Dosing convenience and adherence potential, and then the sixth consideration is adverse effects. So I am presenting mainly today from the hepatitis C guidelines. These are freely available on the web. I would encourage you to refer to these for up-to-date information. So for completeness, I've given you what the treatment of choice is for genotypes 1 through 6. But our patient, which type of genotype did he have? 1B. So really, his treatment choices, he has 5. He could be treated with sofosbuvir ledipasvir, grazoprevir elbasvir, ritonavir boosted paritaprevir, ombidisvir, dasabavir, and he would probably need ribavirin because he has cirrhosis, or sofosbuvir decladisvir or sofosbuvir cimeprevir. So the second consideration was how long to treat the patient. So patients that have cirrhosis may require either the addition of ribavirin or a longer treatment duration. So keep that in mind when you look at a prescription and you see the duration of therapy and it's longer than you were expecting. That may be the reason. And as I mentioned before, protease inhibitors should not be used in individuals with decompensated cirrhosis. Their exposures are increased significantly, and that can cause further liver damage. So these are kind of not great options for decompensated cirrhotic. Okay, so this slide just shows the possible treatment durations for our patient who was treatment naive and cirrhotic, but also treatment experienced cirrhotics and decompensated cirrhotics. I included the last two columns just for completeness, but we are focused on the first column for our patient, and in particular the ones that say genotype 1B. So he could be treated with sofosbuvir ledipasvir, and it would be for 12 weeks. Prod with ribavirin for 12 weeks. Grazoprevir elbasvir for 12 weeks. Sofosbuvir decladisvir, you need to add ribavirin in cirrhotics, and that would be for 12 weeks. And then he could be treated with sofosbuvir and cimeprevir, but it's very expensive as is, and now you've got to give it for 24 weeks. So really, that one's kind of off the table. Okay, so here's the cost of these medications. No hepatitis C talk is complete without me showing you the cost. So this is the wholesale acquisition cost for a full course of treatment, for 12 weeks of treatment. So it's very expensive. And this isn't necessarily what we're paying because of all the negotiating with the insurance providers and the Colorado Medicaid program, other state Medicaid programs. The cost is actually cheaper than this in many situations. But if we treated everyone that had hepatitis C right now, the cost of that would be very similar to the cost of all medications used in 2015. So it is sort of cost prohibitive to treat everyone at once. And so we're having to prioritize in some cases who gets treated. So we wouldn't use sofosbuvir, cimeprevir, sofosbuvir decladisvir because we can get the same benefit from these other therapies and they're cheaper. Okay, so this is the Colorado Medicaid situation for Hep C treatment. Treatment is prioritized to individuals that have extrahepatic manifestations of disease. So this is mostly a liver disease, but there are complications that can be extrahepatic, like renal problems, glomerulonephritis. You know Natalie Cole that recently passed away? She had Hep C, and I believe from reading about her kind of clinical case with Hep C that she had glomerulonephritis from her hepatitis C. And so it made it really difficult to treat her with interferon-based treatment. It didn't work. She couldn't take the ribavirin. She even had to have a renal transplant, I believe. So these can be a real problem. We prioritize individuals that have a fibrosis score of 3 or 4, other evidence of cirrhosis. So it's not just a biopsy. You could have imaging evidence of cirrhosis. Anybody on the liver transplant list or that has hepatocellular carcinoma can also get treated through Medicaid. Right now, PROD is first line. That's that ritonavir boosted paritaprevir, ombidisvir, dasabavir therapy. They came in more cheaper in the negotiations, but this could change with the new approval of grazoprevir and elbasvir. But just to give you a sense of how often this is approved, of 5,200 HCV-infected individuals that are covered by Colorado Medicaid, 645 of them have requested hepatitis C treatment, and only 175% were granted the therapy. So that's a 76% rejection rate. So there are a lot of people who want to be treated that currently cannot be treated. So the fourth consideration is drug interaction potential. So rather than get too detailed with this, I've created a spectrum here of minor interactions, some interactions, and lots of interactions. The best resource for looking at drug interactions with hepatitis C therapies is the University of Liverpool site. That's hep-druginteractions.org. This is a great resource for looking up not just hepatitis interactions. They also have one that's HIV drug interactions, so you can look up HIV drugs as well. It's great. Sofosbuvir has a very low potential for drug interactions. It's not devoid of interactions, however. It is a substrate for the drug transporters P-glycoprotein and breast cancer resistance protein, so you can't use potent inducers like rifamycins, St. John's wort, or some of the old school anti-epileptic drugs because they would significantly decrease the exposures of sofosbuvir. And this isn't unique to sofosbuvir. This is true of all hep C therapies. They cannot be given with those potent inducers of PGP and BCRP. Declatosphere and ladipasvir have some interactions. They are primarily victims rather than perpetrators in interactions. But they do, declatosphere, as I mentioned before, it is a substrate for CYP3A4. You have to adjust its dose based on the other medications that you're giving in addition to the hep C treatment. And then these drugs can inhibit transporters also. So OP1B1 is an uptake transporter in the liver, and whenever you hear about OP1B1, you should think statins. And so there are statin interactions with the hep C therapies. And then grazoprevir, elbasvir, and PROD have lots of interactions, both victims and perpetrators in a number of interactions. Use the website to look those up. Okay, and here are some therapeutic classes, just to give you a sense of the ones that we have to worry about or not worry about. Methadone's fine, and that's good news. Oral contraceptives are fine, except with PROD or with PRO. In a healthy volunteer study, they found that when they gave ethinyl estradiol-based oral contraceptives with the ritonavir boosted paritaprevir, that there were a significant number of patients that had an increase in LFTs. So we should not be using ethinyl estradiol-based contraceptives with PRO or PROD. Amiodarone. So surprisingly, individuals that were taking sofosbuvir-based hep C treatment, also on amiodarone, had significant serious bradycardia, including fatal cardiac arrest. We don't know if it's a drug interaction or not, but it should not be used with any of the hepatitis C therapies. Gastric acid modifiers, I mentioned, were problematic with ladipasvir. Rifamycins, anti-epileptics, they're potent inducers. They should be avoided. Look up the statins, calcium channel blockers, and HIV medications. These are some classes that may have the potential for clinically significant interaction. So right now, there is some language in the sofosbuvir ladipasvir product information that tells you how they think you can safely use gastric acid modifiers. You can give antacids as long as it's separated by 4 hours. You can give a 20 milligram dosing equivalent of omeprazole as long as you give it in the fasted state. You can give famotidine as long as you don't exceed 40 milligram equivalent BID. But this is a lot to remember. And you all know people can go to the pharmacy and get gastric acid modifiers without you even knowing. So, this is an important counseling point with this medication. And a recent study, so we don't have all the specifics with this study, but it's a real-world cohort of patients across the country that were treated for hep C that weren't part of clinical trials. And they found in this study that individuals that did not get a proton pump inhibitor or did not have a proton pump inhibitor listed in their record had a higher chance of being cured. So until we get more specifics on this study, it worries me a bit using gastric acid modifiers with sofosbuvir ladipasvir. They did find that if you did not give these medications simultaneously in the fasted state, that ladipasvir could be reduced by up to 90%. So that's a huge reduction. Okay, dosing convenience. So I already gave you a sense for the pill burden. Some of these are 1 pill once a day. Some of them could be up to 9 or 10 pills a day. And then you have QD options, BID options, and then the treatment duration is, of course, a consideration as part of adherence potential, whether or not they only have to do it for 3 months or whether they're going to have to do it for 6 months. Adverse effects. So take a look at the percentages of these. I don't think they're bad. And I guess because I come from working with interferon and ribavirin, I actually think they're quite good. Most of the patients that receive these medications have very few complaints. They may have headache. They may have a bit of nausea, but really it's a really well-tolerated treatment. You'll see the rates go up, though, when you add ribavirin. So you have more toxicities when a patient has to take that medication. So in terms of patient monitoring, our patient has genotype 1B, but if he had 1A, we would have to do a resistance test before he started the grazoprevir/elbasvir if we choose to use that, because he could have some of those mutations. In terms of viral load monitoring, we want to get one at baseline so we know where we started, another at week 4, and then the guidelines say you don't have to get another viral load until you're assessing them for cure, 12 weeks after they've stopped treatment. An important point about that week 4 on treatment viral load is that you're not going to make clinical decisions based on it, really. There's plenty of studies showing that you can have a detectable viral load at week 4 and still go on to achieve a cure. So it doesn't mean that you need to act on it if you have a detectable viral load, although you may want to encourage good adherence, make sure they're taking the medication as prescribed, because one of the reasons they could still have a detectable viral load is potentially non-adherence. In terms of safety, we get those pretty much monthly, a CBC, serum creatinine, calculated renal function, liver function tests. Okay, let's say he's cured. Yay, we did it. There's a quote by one of my colleagues in Chicago that says, "There's no divorce in cirrhosis." So even if you've cured this guy, you still have to see him. He'll have to continue to have screening for hepatocellular carcinoma and varices. Now, you've reduced his risk for those complications to almost nothing, but it's still there. So he still needs to be screened, okay? And an important counseling point, if you've been cured of hepatitis C through antiviral treatment, that does not make you immune to hepatitis C. You could go out and get it again the next day. So risk reduction is a really important part of counseling once you've cured someone of hep C. Oh no, he didn't get cured, he relapsed. That's awful. Now what do we do? Well, this is luckily a small percent of patients. Right now, it looks to be only about 5 to 10% of people that we treat do not achieve cure. But still, we have to figure out what to do with those individuals. It's easy for people who failed samepivir/sofosbuvir therapy. We can retreat them with an NS5A-based treatment, and they still have a great chance for cure. But we're still figuring out what to do with people who fail an NS5A-based treatment. So we don't exactly know what the best treatment for these individuals is right now. Half that fail are going to fail with NS5A resistance mutations, which will make future NS5A-based treatments less effective. So resistance testing may be helpful, but we're still figuring out. Maybe try to get them into a clinical trial if possible. That would be the best solution right now. So what does the future hold? Let's look into the crystal ball. In June, we will have another fixed-dose combination tablet with a NS5A inhibitor that is more pan-genotypic. So it covers more genotypes, should cover hopefully all the genotypes. And we're also trying to shorten that treatment duration. So there are a couple studies looking at 6 weeks and 8 weeks. One recently presented in November showed that if you use sofosbuvir, velpatasvir, and an investigational protease inhibitor, all 3 of those drugs together, that you could have a 100% chance of SVR. So in summary, in recent years, there have been significant advances in the treatment of this disease. There are several important considerations in selecting a treatment for an individual, and you need a systematic approach to identifying and managing drug interactions. And I think there still needs to be more focus on testing and diagnosis and access to medications, because getting back to one of those first audience response questions that I asked about whether everyone should be treated, my opinion is that everyone should be treated. Hep C is curable, and that everyone should have access to these life-saving therapies. Okay, thank you.